Welcome to the noontime keynote. We are definitely in for a treat for our keynote presentation today by Dr. Daniel Dawes. So Dr. Daniel Dawes, among some of his accolades, hold on one second. People who are in the background, can y'all mute yourself, please? Thank you. Thank you. All right, so Dr. Daniel Dawes is a widely respected healthcare and public health leader, health policy expert, educator, and researcher who serves as executive director of the Satcher Health Leadership Institute at Morehouse School of Medicine. He's also professor of health law, policy, and management. He's the author of 2 groundbreaking books, 150 Years of Obamacare and The Political Determinants of Health, both published by Johns Hopkins University Press. He has a ton of achievements that we could list, and that you can read it in his bio, which you probably already have, including being the principal investigator for the nation's first health equity tracker that he's going to talk about today. Among all of his other many hats that he wears, he serves as an advisor to the White House COVID-19 Health Equity Task Force and serves as an appointed member of the CDC's advisory committee to the director and NIH's National Advisory Council for Nursing Research. So today, Professor Daniel Dawes will detail the impetus of the groundbreaking Health Equity Tracker. The tracker is a data platform that highlights the disparate impacts of COVID-19 on marginalized communities. It's built by the Satcher Health Leadership Institute at Morehouse School of Medicine, and is supported by Gilead Sciences, Google.org, and the NECC Foundation, also the CDC Foundation. So Professor Dawes will share his insights, how the tracker enables key policymakers to find data-driven solutions that create equitable policies for us all. So please, as he's talking, put questions in the chat, because at the end we'll have a Q&A, and I'll be looking forward to receiving some really cool, interesting questions. Professor Dawes, you want to take it away?
Absolutely. Well, let me first thank you so much for that very warm introduction, and good afternoon, everyone. It is so exciting to be here, and it's always an honor, Dr. Washington, to share that virtual stage with you. And of course, I thank you for the opportunity to highlight the wonderful work we've been doing at the Satcher Health Leadership Institute here at Morehouse School of Medicine to address the digital and the political determinants of health. So before I begin, I just want to take a moment to really salute all of our data scientists, our public health, healthcare, and bioethics scholars and leaders and learners for their courageous and humbling work that you all have been doing during this very dark and historical moment. You know, in fact, I really appreciate the work you've been doing to elevate the health, to elevate health equity in our communities during this endemic. And, you know, as I think about what this period of time means, what it represents, I'm reminded about an experience I had with my brother a few years ago. I had just gotten my driver's license, so we borrowed my mom's car, and my brother and I decided to visit a new church. Once we got there, we noticed the seats available were in the last pew. So we reverently and hurriedly walked to our seats, sat down, and not even 5 minutes passed, and my brother, my younger brother, like so many kids do in church, starts nodding off, right? Well, when I looked to my right, I noticed my brother nodding off, and I nudged him, and I said in a hushed voice, "Patrick, wake up." His head rose, and he says to me, "Leave me alone. I'm tired." Then 3 minutes later, I see him falling asleep again. And I nudge him even more, saying, "Patrick, you're going to miss the sermon. Wake up." At this point, he raises his voice and he says to me in an annoyed way, "Leave me alone. I told you I'm tired." At this point, a couple who was sitting in front of us turned around and shushed us. So I decided to leave him alone. Well, not even 5 minutes passed, and the preacher gets up to the podium and he immediately shouted, "Wake up! Wake up, church! We gotta wake up!" And my brother immediately jolted up in his seat, astonished and embarrassed because he thought the pastor was talking directly to him. He wasn't, though. He was talking to the entire church. Well, I tell this story not to embarrass my younger brother, but to remind us that sometimes we all need a wake-up call to jolt us into action. Because you see, like my brother's wake-up call in church, America has been having a similar experience. By my count, we are now in the fourth period of a great awakening for health equity in America. These awakenings include Abraham Lincoln's policy to provide health care to newly freed Black people and poor whites, desegregation of hospitals in the 1960s owing to Medicare and Medicaid legislation, the passage of public policies addressing minority health and health disparities, including the landmark Affordable Care Act or Obamacare, and of course, the current moment under the Biden-Harris administration, which for the first time in US history is harnessing the powerful levers of the federal government to advance health equity and address the upstream determinant of health inequities. We all know that the long arc of history eventually bends toward justice. But as it bends, it can also wobble, right? Notwithstanding the fact that we have entered a new period in our health equity movement, according to recent articles published by BMJ and Health Affairs, research is showing how little progress we are making in eliminating health inequities. Within healthcare and public health, we are awakening to the ways in which research has falsely looked at race as a biological attribute rather than a social construct over centuries, contributing to systems of racism in healthcare delivery, education, housing, transportation, employment, and public health. And at long last, public health science, medicine, nursing, social scientists declaring that race is not biological, but that racism has profound consequences for health. To address this unfinished business of healthcare and move the needle of health equity to a meaningful degree, it's going to take greater action from all of us, harnessing the power of collaboration within communities disproportionately affected. So, this begs the question, how can we leverage this moment to build trust in under-resourced and minoritized communities, ensure they have the data to tell their stories, improve action and gain insights to help these communities, advance their priorities, and of course, improve equitable access to breakthroughs to advance health equity? Well, let's start with the trailblazing social epidemiologist, Dr. WEB Du Bois, whose work was over a century before its time. Most notably, his 1899 groundbreaking study, where he brilliantly adapted the public health epidemiologic triangular model of disease transmission to a social context. And from this, we began to understand that biological factors do not act alone, but in concert with structural conditions, which, acting as parasitic vectors, are transmitting and exposing individuals to health risk factors such as racism, discrimination, and other inequities, which he classified as the determinants of death. Think about that for a moment. Yet, it would take another 100 years before the United States would exalt or even recognize any relevance of his work in the Institute of Medicine's landmark report on equal treatment, confronting racial and ethnic disparities in healthcare. And then, of course, another decade and a half after that for the world to recognize these health risk factors or determinants of death, which Dr. Du Bois originally identified as the social determinants of health that we know them as today. Well, just like Dr. Du Bois, advancing equity is at the core of everything we do at the Satcher Health Leadership Institute. And so we share the same charge, fighting for health justice. through health system transformation, addressing mental and behavioral health inequities, and focusing our efforts in addressing those political determinants of health that have created the structural conditions we are born into, we live in, and we die in. But before I discuss how we are accomplishing this through one of our projects, the Health Equity Tracker, I want to first discuss the emergence of a new topic, one that is very concerning, right? A very concerning driver of health inequities in America and globally, the political determinants of health. Most of you, I'm sure, are pretty familiar with the social determinants of health, those determinants of health driven by where we live, we eat, we work, worship, and play, that bear influence on our health outcomes and life expectancies. But let's discuss what has been motivating us beyond nibbling around the edges of health inequalities and focus our attention on creating systemic change for Black, Indigenous, and other communities of color. It is our focus on the instigators and perpetuators of the social, environmental, and other determinants of health, the more upstream factors that I refer to as the political determinants of health. You see, these political determinants of health involve the systematic process of structuring relationships, distributing resources, and administering power, operating simultaneously in ways that mutually reinforce or influence one another to shape the opportunities that either advance health equity or hinder health equity. You see, it is the political determinants of health that I believe and I argue play the most outsized role in the perpetuation of inequities in our society, given the fact that they inequitably distribute social, medical, behavioral health, and other determinants, and create the structural barriers to equity for population groups who lack power and privilege. But that is not the full story, not by a long shot, because there is another set of determinants of health lurking about that are being leveraged for just as much good or evil as the political determinant, the digital determinants of health. So while technology has inarguably added value for our society, it is still not free of fault. The old adage that knowledge is power comes into play, certainly. And like all powerful tools, the intention behind its use determines the fruits of its labor. Technology and data specifically, if used incorrectly, can be detrimental. Recent discussions in the Lancet now share a similar concept in the technology space, whereby digital determinants of health are in existence, which can also be influential in impacting the health outcomes of population groups. These relate to the inequities in digital health and related technology design and applications, as well as digital and technological conditions that influence individual and group differences in health status. We have become increasingly reliant on data to drive decisions, including health decisions. Imagine if this data differed from region to region because of variations in collection practices, or were inaccessible, or even worse, did not exist altogether. What then would have been the basis for the health precautions and recommendations provided to the public at large by our governing entities, such as our public health agencies? Where would the state of this country's health be today? Think about that for a moment. Well, the truth is that you don't even need to have a creative imagination to visualize what the scenario would look like, because we already know what it looks like. Take a look around. It looks like today, quite frankly. Sadly, we're living in precisely this reality. Despite this increased reliance, we still have many challenges. And without a working knowledge of data to drive decision-making, the movement for health equity is hindered. We know that access to data and technology, like having broadband access, technical proficiency, and other variables, can limit the options for certain populations to receive healthcare and public health services. among others. Another modern day example of this is our increased reliance on telehealth, as we've observed during the pandemic. The inability to access telehealth services due to technological constraints can cause unnecessary exposure for certain groups of people, such as older adults, people who are immunocompromised, or people living with comorbidities, putting them at increased risk, right? To put it bluntly, the digital determinants of health have the potential to impact the health outcomes of many populations, much like racism, race, gender, ethnicity, and socioeconomic status. So it is to the best of our interest that we recognize these shortcomings so that our work and data specifically continue to live by the do no harm motto or mantra, right? So unless we address these multiple intersecting determinants of health, especially the digital and political determinants of health, we will continue to experience striking health inequities among our population groups. Just take a look at what America currently looks like in terms of life expectancy if we disaggregated by race, made each group its own country, and compared them to the rest of the world. White America would rank 50th in the world. Black America would rank 103rd in the world, more than twice. And Native Americans would rank 143rd in the world in terms of life expectancy. You know, this really is a sad and unjust display of how the determinants of death divide us as a country and perpetuate health inequities. So, how can we achieve an equitable response? Is that even possible? Well, to date, we've never been able to realize or achieve an equitable response to a pandemic in the United States. Not only have we failed to have the information that we needed, we failed to have the right information. Sadly, history repeated itself again in 2020 when COVID-19 made its appearance in the United States. Well, when we realized that COVID-19 was going to strike America, my team and I conducted our due diligence to understand how pandemics have impacted communities of color and the challenges that prevented an equitable response. What we found, going back all the way to 1793, when yellow fever struck the United States, is that it's the same groups of people who are on the downside of opportunity and advantage who are always most negatively impacted. When we reviewed the studies, going back all the way to 1793, it became glaring to us that the lack of data or access to data was a major problem that we've struggled with here in America for centuries. So in the spring of 2020, my team and I thought surely we could stem the tide of the pandemic in light of the over 7,000 peer-reviewed journal articles published on health equity, as well as with the technological advancements realized over the last few years. We went immediately about helping to found a coalition called the We Must Count Coalition to press for the collection and reporting of disaggregated racial and ethnic demographic data after we got pushback from multiple cities and counties and states who refused to collect or publicly report the data on the number of COVID-19 cases, hospitalizations, and deaths. Finally, we said enough is enough. And through the coalition, we succeeded in convincing South Carolina, Virginia, Wisconsin, Michigan, and Illinois, and the list goes on. We also leveraged this coalition to advocate for data infrastructure modernization and data standardization, after which we began an ambitious undertaking to map and track health inequities once and for all in America. And as of today, we are just 3 months shy of our 1-year anniversary of having launched the Health Equity Tracker. And although we are proud of the work and the progress we have made to date, the truth is that the need for a tracker of this sort means that we have reached a dire point in our history. You see, the Health Equity Tracker was born out of the raging wildfires of injustices caused by the COVID-19 pandemic and this endemic, specifically in communities of color. The reality is that we cannot statistically point to the harm being inflicted on, or if we can't statistically point to the harm being inflicted on and endured by a given segment of the population, then we will continue to facilitate with ease the adage that if there is no data, then what? There is no problem, especially to those in power. Well, understanding this need to take action, on May 26, 2021, in partnership, as you heard Dr. Washington mention, with the CDC Foundation, the Annie E. Casey Foundation, Google.org, Gilead Sciences, and AARP, we launched the first of its kind health equity tracker, enabling us to provide a source of information and a tool for policymakers, policy influencers, and community leaders alike, so that they may advocate more effectively for the prioritization of health equity. Now, our tracker is a scalable data visualization solution platform that ingests multiple data sets, highlighting demographics, as well as, in the words of Dr. Du Bois, other determinants of death, such as COVID-19, various chronic diseases, mental and behavioral health conditions, and the social and political determinants of health for a total of 24 variables. What we wanted to do was not create a health disparities tracker, but a true health equity tracker, connecting the dots to the drivers and the determinants of these health inequities in our communities. As new barriers, such as the digital determinants of health, emerge and the political determinants of health evolve, we must be able to collectively meet and beat them with new tools and platforms, such as the health equity tracker, to help bridge and overcome the added challenges. So let's discuss the inner workings of our health equity tracker for a moment. Through the power of data-driven storytelling, we brought to life a visual map of the abounding inequities in America. The tracker highlights data gaps, such as states shown in gray, whose data has been suppressed due to the unreliability in data reporting, as well as looking at disaggregated data. For example, the breakdown of the population by race and ethnicity, age, and gender. The Health Equity Tracker helps to comb through the pages of the internet to bring information into one platform. So for instance, the platform allows for our COVID-19 vaccination data to seamlessly combine the best sources for demographic information on vaccines in the United States, the CDC for national numbers, the Kaiser Family Foundation for state level race numbers, and the list goes on. The design of the tracker essentially allows us to tell one story to our users using the different sources, while still being very transparent about where we are getting our data and what kind of data is still missing. The alternative really would mean that you would have to search through potentially hundreds of thousands of websites and other sources for the same data that we are visually presenting on a single platform. The Health Equity Tracker also helps to address the issues of literacy, which I believe is a major problem that we have also seen, right? In addition to that, data democratization. Unfortunately, as many of you know, not all data is easily accessible or even accessible at all. Some data is restricted, and it takes us jumping through hoops and over hurdles to gain access to it, and that's if we can even achieve it. We did so, and we went through an application process to be able to obtain the CDC's COVID-19 restricted access data set so that we would, for instance, be able to share it with the world. But once we obtained the data, we encountered the issue of data literacy, right? You see, the data is complex and convoluted. We had to process it by using subject matter experts, software engineers, data scientists like you all, and social scientists to provide a clear visualization of the data. And we intentionally provided the ability to read the data in several formats, as you can see on your screens. A general map of the US with numbers highlighted when the mouse hovers over it, in bar chart formats to show comparisons, or in simple chart formats. We provided explanations to our methodology and breakdowns wherever possible. And we've eliminated use of complex language wherever possible, and also adopted use of equitable terminology for inclusivity. In terms of accessibility, we were conscious of our selection of colors to eliminate barriers for people who are visually impaired, which are often overlooked in the website design and development space, so that they could more effectively navigate our space, navigate our site, and help their own communities. Now, more importantly, we are proud that our health equity tracker is the first in the nation, developed by an HBCU that has respected data sovereignty among tribal nations. To us, the notion of data sovereignty and the explicit decision to prioritize such goes beyond the technical definition. It is not just about respecting the governance of data related to sovereign nations and tribes, but also respecting and prioritizing representation from each and every marginalized community. In our eyes, every individual group and their data is sovereign and should be treated as such. And so to this effect, their data should be an accurate representation, and they should have a voice in the handling of such. We were able to accomplish this on our health equity tracker by bringing together a task force of representatives from all walks of life across every geographic region of the United States, including the US territories, for the purpose of making sure that we represented the data as accurately and equitably as possible. Which leads me to my next point, data disaggregation. Being able to dissect big data or aggregated data is important because this is where the narrative is hiding. Disaggregating the data allows us to look at the specifics of a situation better. For example, our tracker disaggregated COVID-19 data so we're able to drill down to the county level. And lastly, is the issue of data gaps that, and I'm going to use the word gaps loosely, to encompass a variety of things. Some data were not disaggregated enough for us to be able to use in our tracker. Due to variations in data reporting, some data was excluded because it may not have been accurately representative. Collectively, these scenarios contributed to data gaps. In our tracker, you will notice that we highlight them in various ways, such as yellow banners or color-coded in gray on our state map. All of this effort collectively would in turn ensure that we have advocates who were in agreement with how the data represented their community. But our work is far from being done. So this begs the question, where do we go from here? Where do we go next? Undoubtedly, the road that leads to equity is one that has never been traveled. It is long, winding, and filled with numerous potholes to repair. We hope that by presenting the data in such a way, others will feel confident as they navigate this treacherous path. We want scholars and researchers to view the Health Equity Tracker as a data source. We want professors to use the Health Equity Tracker in their classrooms to educate. We want health equity champions to advocate for their communities using informed decisions guided by the Health Equity Tracker. We want policymakers and policy influencers to help uncover the narrative and activate the right resources to the right communities, the ones that historically have been overlooked in our country. And we want the people who are closest to the pain, closest to the problem of health inequities, to be the ones leading the solutions moving forward. In fact, it's what we must do and what must happen for equity to be front and center in any and all conversations. As a scientific community, we must collectively advocate for policy changes that reflect more equitably, right, or more equitable data, so that we in turn can make better and more informed decisions. Many of you here today serve as guiding lights that we all look up to for the work you continue to do. I know that without your work, there might not be any of my work. And the work that we, both you and I, are engaging in is absolutely vital in order to achieve a more equitable tomorrow. Dr. Du Bois left us with many enduring principles and even more inspiring words. But one quote in particular speaks to me in moments such as these. He said, "Now is the accepted time, not tomorrow, not some more convenient season. It is today that our best work can be done, and not some future day or future year." I am confident that the work we are doing today will have an immediate and lasting impact on the health equity movement as we look toward a future day of a future year. I want to thank you all so much for the privilege of your time. I believe that with your continued contributions in our movement, we will be able to create and advance health equity to a degree that Dr. W.E.B. Du Bois and other trailblazers envisioned for all in America. Thank you all so much again for your time.
Thank you so much. That was great, really impactful. And if you all haven't had a chance to participate in the poll, it's about to close anytime. So go ahead and put your items there in the poll. So there are a number of comments that are happening in the chat. If anybody has any questions, please put them in the Q&A. People say they appreciate the accessibility considerations, how it's culturally relevant, and that the website is really well done. And it's an amazing tool. So kudos to you and your team for creating such an awesome resource for the community. So I'm just going to go to the first question for you. Suppose I have my statistics and data science students use data from the Health Equity Tracker for a class project. Where might I send any interest and results in order to share them so that others could use them or add to them?
So explain that to me. If you collect the data from our tracker,
yes,
where can you use it?
Let me give you a concrete example. So in the fall semester, Dr. Sandra Rucker, who's chair of the Department of Mathematical Sciences at Clark-Atlanta University, used the Health Equity Tracker in her class, and they did research projects, and the students generate findings. Well, other people might have students do projects using your Health Equity Tracker. Where could they submit that information to and share that information?
Oh my goodness, that is a great question. Thank you for that. So, the intention of this tracker was to make sure that those at the grass tops had a resource that they could go to, right? So these are our scientists, our researchers, the policy influencers, the advocates, the policymakers. And so I would submit that what we are trying to do is to make sure that this data, that this information, once it is analyzed, is used in a manner, whether you want to use it at the grassroots, although we built it for the grass tops, but we do encourage its use at the grassroots level, at that community level. We need to share that information out. I think, it would be great if folks would join us. We have a network called HELEN, our Health Equity Leadership and Exchange Network, which has over 2,600 researchers, leaders, quite honestly, it's a very diverse group of folks. And it was intended to exchange data, to exchange information with one another. So if folks are interested in sharing that broadly, once they've conducted that research, I would welcome them to join HELEN. It's healthequitynetwork.org, and share your results, right? So then we can use that within our respective networks or in their respective networks where we might not have touch, right? So I would thank you so much for including that. Thank you. So that would be a great opportunity, I think. I think sharing that information with your policymakers, sharing it with the leaders of your churches, your church members, or other faith sites would be really important. We know there's a lot of misinformation right now, and we're having a difficult time, as things change very rapidly during this pandemic, getting that information out. So to the extent that students are working on projects, professors are utilizing this data. I would say, please share that with us too. We have a blog on the Health Equity Tracker where we're featuring, folks who are using the data. So for those researchers at the AUC who are using that, and you'd like to highlight for us maybe a very interesting narrative that is coming out of the data that we haven't caught, we welcome your contribution so we can amplify that to folks who are looking at this information. And this information goes to journalists, policymakers, and so forth.
Awesome. Thank you. Yeah, it's a great question. So somebody asks, what are good practices to get, the questions jump around. What are good practices to get non-data scientists involved in data science?
Ooh, well, I think that would be what we strove to do. So I'll tell you, I don't know if it's a best practice, but it worked for us, quite frankly. So I'm a non-data scientist, right? And this is why I said I always bring together the folks who are the best and brightest in each of these fields. We know that health equity, health justice, health inequities are multidimensional issues, right? And it's going to take harnessing the power of transdisciplinary collaboration with everyone's unique lens, adding value to this effort, right? And so I think that what worked for us when we were building this health equity tracker was that we brought folks that we had never traditionally worked. We talk about at Morehouse School of Medicine how we embrace interdisciplinary collaboration, right? But that's within the health sciences. And I had never before worked with engineers. I hadn't worked with data scientists. I had worked to an extent with social scientists, but we brought all these groups together, right? Experts that had these lens and experts that had lived experiences, folks who represented and had been working on minority health and health inequity issues their whole careers. We brought them together, those who may not have had an equity lens per se as data scientists or engineers, with those who actually had that lens. And let me tell you, the magic happened, right? Because when you bring exceptional people together, magic can happen. And that's what we saw with the Health Equity Tracker. So I think we actually have written about how we conducted this process, and I'd be happy to share it with you if you're interested in learning exactly how we did this, how we built it.
Awesome. So what are the biggest insights the Health Equity Tracker has surfaced since it's launched? And when did you go, wow, I didn't expect this?
Yeah, I would say for us, the good thing about this tracker is we can do comparisons, right? And I think, it really, I guess for us initially, it justified or validated what we had believed was happening to begin with, that Black and brown folks were being disproportionately impacted by COVID-19. But again, nobody wanted to reveal that data. Once we pulled that in, after The Atlantic had actually convened a group of 500 folks, volunteers, to manually pull together the data, and they closed in April of last year. We then, once we operated, we were then able to pick up from that and continue to tell the narrative. And what it did show us was that, wait a second, it's interesting that in this community, New Orleans, for instance, we saw 70% of the deaths being attributed to African Americans, right? We saw in parts of Georgia, in Athens, Georgia, for instance, that the highest death rates and hospitalization rates were among Latino individuals, right? We got to pinpoint when we added the vaccination information. We got to see first, before everyone else saw this, that those in Puerto Rico actually had some of the highest vaccination rates. How is that? Why was that happening? That was remarkable, right? Or that there were certain Native American communities that we saw higher rates in certain regions of the country. What was going on there? And we were then able to connect with those leaders to say, tell us about what you're doing very well, right? Why is that happening? We also then saw, really, when you think about this on the negative side, which states constantly refused to update it. And we could tell when we updated it, which states were taking much longer to update their data sets, right? Those that were lingering, those that refused, if you will, to pull in or disaggregate the data. So for us, it was really telling to see which states were on the ball when it comes to data collection and reporting, which states we would have probably given a grade of an F, right? So those were some of the highlights. We also got to see then, when you look at the comorbidity data, right? Very fascinating, again, that we could see which comorbidities in which regions were actually on par with the higher rates of COVID cases, right? And then we could also then do, beyond the social vulnerability index that CDC has created, we wanted to look at what this means then when you look at, for instance, healthcare access in America, right? Where are those areas in the country that have some issues with accessing care, which we know predominantly are communities of color, but which ones more specifically are most negatively impacted, right? As we try to align resources with the greatest need. So that has been extremely insightful. And we're not even done yet. We have a team of legal epidemiologists that have been working now to analyze the data, right? As we look at these social determinants of health, or the determinants of death, as Dr. Du Bois called them. And we are connecting those to their policy, their political and policy roots, right? So that, again, we can understand what has been exacerbating or perpetuating these inequities in these communities, and how can we repair them moving forward. So those are some of the things that we have seen that I thought were pretty compelling. The other one is, for older adults, we can pinpoint exactly which groups of older adults were most negatively impacted by COVID hospitalizations, by COVID deaths, by cases, and so forth. And then we can disaggregate that by race and ethnicity, which has been really, really interesting, again, as we try to align resources with the greatest need, as we try to work with policymakers in these states at the federal level to ensure that they are aware this is happening.
Right. So there's been a push to get more data from diverse communities. And so somebody asked, can you talk about community hesitations to offer up our data? And how do we build this trust? And what about community ownerships? What are your thoughts?
Well, I appreciate that question, because that is something we were very mindful about when we were creating this. We had heard from indigenous population groups in Alaska, in Hawaii, and here in the contiguous 48 states, that they had issues with what other universities had done relative to their data. I will not call them out, but they know who they are. And they basically would take the data from these communities, although these communities had protested and said, wait a second, that is inaccurate. We want to work with you to ensure that data accurately reflects our issues, what you're highlighting. And so there were a lot of indigenous groups, I must say, who were extremely weary when we got to the scene and said, well, are you going to be doing the same thing to us that these other universities have done? And we said, as a matter of fact, absolutely not. We are about doing no harm. We want to make sure that whatever we create is created by the very people who are most negatively impacted by health inequities. And so we welcome your expertise in making sure we get this right. And it did take time, right? There were folks who were rushing us. When are you guys going to get this done? They wanted us to build a health equity tracker in 3 months. Can you imagine? But as we know, trust takes time. And although we have had some relationships with various tribal nations, we didn't have, very solid relationships. So we were trying to build out our footprint in these communities. We had very solid footprints in African-American communities, right? And we were able to work with policymakers and public health officials who trusted us already, right? Believing that what we were doing was intended absolutely to benefit the African-American community. And then with Latino communities, we then also identified and worked with trusted leaders in these communities, folks who had expertise and who identified as Latino or Latinx. And so it was a remarkable group of folks. We had Asian Americans. We looked at multiple statuses. We wanted to make sure we had LGBTQ plus individuals, people with disabilities. We had older adults. We had younger folks coming to the table, women, men, you name it, right? So we wanted to make sure that we had a very diverse group of folks who would come in and challenge us about where we had potential weaknesses, to help guide the engineers and the data scientists who didn't necessarily, as they were working with us from Google and other companies, who didn't necessarily have an equity lens, that took time then to make sure that they understood. So one of the reasons why it took us a year to build it was we had to spend 6 months educating the engineers and data scientists about what equity truly means, right? And what equity and data science intersection really means. And so through that effort, I think we were able to convince these leaders that our engineers, our data scientists, our entire team at the Satcher Health Leadership Institute were really thoughtful in how we were progressing. And I think that helped. And through that work, it helped us to think more critically, right, about where there were challenges, where there were gaps, where we could run ourselves into trouble if we weren't careful. And so, as you can see from the site, healthequitytracker.org, you'll see that we took painstaking time to make sure that we were as inclusive as possible. And for those who may see something on there that, wait a second, may sound some alarms, we welcome the constructive criticism because we want to make sure that we do no harm.
I like the idea of bringing diverse communities to the table as an intellectual thought partner, not going in trying to save anybody, but having them be the intellectual thought partner and welcoming the challenge and questioning, making sure things are on the right track. I really do appreciate that.
Sure.
So somebody asks, what is your philosophy on engendering trust in the participants for donating their data? Do questions of ownership of or compensation of personal data or other samples arise in your work?
Well, I would say that it is absolutely front and center of what we are doing. We, there were some issues with, are we taking private data? As you heard me mention, we actually cull our data from public sources, right? Those that are already available. So what we have been doing is trying to think about it. When we get into the private data sphere, right? As we work now directly in communities, as we're collecting that primary data, we want to make sure, of course, that we don't take these communities for granted, that we don't repeat what others have done to communities of color in taking and extracting and not giving back, right? We want to make sure that whatever is retrieved in concert with these communities by permission, that they are compensated accordingly for their data, for the material. And I will say that we believe that, of course, with the groups that we're going to assemble to make that happen, I think we will do that much better than others. Now, we may have some, obstacles along the way, but it's surely front and center in our minds once we enter that space. We're not there yet. So for those who are on today, who have expertise in that area, we welcome your collaboration, because I will not say that I'm an expert at all in engendering trust when it comes to data collection and reporting. But
it sounds like your tactics really are intended to build trust.
Sure.
Yeah. So somebody asked, and I think this may be the last question. So what kinds of ways can we as a data science community keep pushing on equity as a foundational piece of data science when sometimes colleagues feel more interest in just the technical side, not the social side, but the technical side, like doing fancy machine learning things, but not really understanding the context in which the data lives. So what sort of advice do you have for data science to keep in mind, especially when they're talking about data that impacts lives of other people?
So I love that question too, because it is the great debate that we are having even in academic medicine right now, right? And as well as in other health professions, where there are folks who say, for instance, in medicine, we should only focus on the biology of disease. Why are you forcing me? I'm not into health equity. They see this as an exclusive domain, right? And it's not. I really do believe that for those of us who have that technical knowledge, whether it's in data science or in medicine or whatever, to me, it is negligence not to understand how the work we are doing in data science can impact racial and ethnic groups, right? We talked about the digital determinants of health. This is real, right? Artificial intelligence, machine learning, as you know, Dr. Washington, you've been helping to lead this effort at Morehouse School of Medicine with Dr. Herman Taylor and myself and other partners of ours, right? And it is so crucial that folks who have that technical expertise also avail themselves by taking an equity lens to the work. Because if we truly want to do no harm, and the work that we all are doing, whether it's in data science or medicine or whatever, we should be doing no harm to each of these groups. And I think it's important that, again, we avail ourselves of that lens to this work. It is not an exclusive domain. I think it's negligence if we don't.
I wholeheartedly agree. And I think we have time for one more question. So they say as technology advances, with the current disparities African Americans face, does technology serve to widen this gap faster than in the past, or can it be used to narrow the gap in ways and at a speed unimaginable? So how do you envision the technology to shrink that gap and really bring equitable solutions?
Well, yeah, that's why I talked about the digital determinants of health can be used for good or bad, right? And I think through the work that you are doing, Dr. Washington, and those of our attendees, I think it is so crucial that more of us, right, understand the intersection of equity and the digital determinants, because if we don't, it will continue to widen the gap, right? It will continue to exacerbate the inequities if we're not careful. And so I do think we have a great mission ahead of us to ensure that we are making this very clear outside of our circle here in the AUC, right? As we work with these companies, as we're working with the NIH, as we're working with other entities, that they fully understand the importance of this issue and the intersectionality of equity and data science, and that they prioritize it, right? Moving forward. Because if they don't, we will continue to be hindered, right, in our health equity movement, because we're not able to shrink and narrow that divide. So I think that is absolutely critical for all of us. And we need to continue to build these out. I would love to see health equity trackers, right, or other trackers at the local level even, right, at state levels that can ingest even more data and share that with communities of color to help empower them through this data, right? And not just keep it to ourselves, but beyond, our traditional industries, we are pulling the community in, and we are helping them to understand how this impacts them, and arming them really with the power to use it, right?
Yeah.
To advocate for themselves.
Fantastic. I'm just going to close out by just reading a couple of the results on the poll that we took. One question was, what share of the Black or African American population could have been preventable hospitalizations? 75% or 66 people actually said yes. So that interesting. And then would you like to help improve health equity tracker? So this is a call to the participants that are here today. And they're constantly looking for health equity champions and data scientists to provide feedback and hang out and do some data fun. And so 32 people, or 44% said yes, and 32 folks, 44% said possibly. And we gave them an email so that they could become more involved with you all. So thank you, Daniel Dawes, for your work with the Health Equity Tracker and really bringing forth equitable health solutions for everyone in this country and beyond. Thank you.
My pleasure. Thank you for having me.
Great. And so at this time, we're going to take a break so everybody can get some lunch. You're also welcome to go hang out in a data lounge and go network. Please check out, if you go back to the lobby, check out the info desk. There are a number of links and documents there that are for your information only, I guess, and share. And you can also, I'm seeing a lot of chatter in the chat, which is fantastic and amazing. So thank you all for your participation. We really have enjoyed having you here. And we will see you back soon for the lightning talks that will start promptly at 1:30. So again, you could take a break or go hang out in the lounge, and we'll see you back for the lightning talks very shortly. See you soon.